Hello everyone, welcome to our new How to I episode in English. Today we will talk about evaluation and management of lipodystrophy. It is my great honor to introduce our guest, Professor Baris Akinci, a key global opinion leader in the diagnosis and management of lipodystrophy and a board member of European Consortium of Lipodystrophies. Professor, welcome. It is a great honor to have you here today.
Thank you for the invitation, and I'm really happy to be part of this very interesting project. Thank you.
Thank you for accepting our invitation. So we can begin with first question. Professor, can you tell us how we define lipodystrophy?
Sure. So lipodystrophy is a rare disorder, and then sometimes it can be a bit confusing for the clinicians to recognize the rare forms of lipodystrophy that we are dealing with, because there are also other forms. So in this figure, I will try to explain this a bit better. As you can see here, so there are different disorders that are characterized with fat loss, because when we talk about lipodystrophy, fat loss is the cardinal feature. So, and as you can see here, there are different diseases. There are different, sometimes complex syndromes associated with fat loss. So when we talk about rare lipodystrophy syndromes, so mostly we focus on these two big circles in the center, and then we always try to classify them into two big groups based on their phenotype, which is either generalized lipodystrophy, where the body fat is almost fully lost, or partial lipodystrophy, where fat loss is in a selective and partial pattern. So, however, as you can see here, there are some additional syndromes. One example could be progeroid lipodystrophy, where patients actually present with predominantly other symptoms, but they also have fat loss, and then there is a bit of overlap here. But you also see some additional disorders which are shown outside of these two big circles, like localized lipodystrophy or limited regional fat loss syndrome. So we don't include them in the context of rare lipodystrophy syndromes for some reason, because these are much more common in population. For example, localized lipodystrophy can happen after injections or things like that, and they are usually not associated with metabolic abnormalities due to fat loss. So, for example, somebody injected insulin may suffer from metabolic worsening because insulin pharmacokinetics are affected by the local fat loss, but the local fat loss itself, the adipocyte dysfunction, is not the thing causing the metabolic abnormality in that case. So that's why they're a bit separate for us. One interesting thing here is HIV lipodystrophy, HIV-associated lipodystrophy. It's actually a real partial lipodystrophy, but we are tend to treat this differently and then classify this differently, because most of the experts in rare lipodystrophy syndromes, they are not actually real experts in HIV-associated lipodystrophy and vice versa. So I think that's the main reason these two things are kind of kept separate, and also treatment algorithms are quite different in these forms. So after this short explanation, I would like to just show you the fat loss main features of the four big lipodystrophy categories. So here on this picture, what you see in yellow is the fat loss areas, okay? And then the blue, especially dark blue areas, are where the fat is preserved. And if it is dark blue, then there could be some accumulation of fat as well. So if you look at this picture, and maybe I can use my pointer. Let's see, there we go. For example, here, there's a typical case of congenital generalized lipodystrophy, which means there is near total body fat loss, and it is congenital. It is caused by a genetic mutation. So as you can see, almost everywhere in the body, fat is lost. There are some, very small areas where a little bit fat can be protected depending on the subtype. And the same is mostly true for the acquired generalized lipodystrophy version, but in this one, you don't have a genetic mutation. These people, they are born with normal fat tissue, but at some point in their life, they start losing fat. So, and then for some of them, we can understand the cause. Usually it's autoimmunity, but for some of them, we don't know why this is happening, and these patients are still classified as idiopathic. So in these patients, still fat loss is, affecting the whole body, but sometimes over the trunk, you can see a little bit fat reserved. So, but still typically these two, big populations of lipodystrophy, they have almost full body fat loss. But if you look at partial lipodystrophy syndromes, so we are talking about two big subtypes here, familial partial lipodystrophy, which is the genetic version, and acquired partial lipodystrophy, that's is the acquired version. So in acquired partial lipodystrophy, these patients, they also have normal fat. And at some point in their life, they start losing fat. In acquired partial lipodystrophy, fat loss always starts from the face and neck and spreads downwards. So the lower part of the body, fat tissue is usually protected and can be even accumulated in some cases. So that's the typical fat loss pattern. There are additional clinical features that can help you diagnose these patients, but that's the typical fat loss pattern in patients with acquired partial lipodystrophy. If you look at familial partial lipodystrophy, this could be a little bit confusing because these patients have a genetic disorder, but then when they are born, they have normal fat tissue, so as small babies, so you don't see a significant fat loss at all. But when they grow, so when they become children and then close to puberty, adolescence, so then their phenotype becomes more obvious. So in this subtype of partial lipodystrophy, fat loss always affects the lower part of the body, and most of the time, upper extremities are also affected. But if you look at the upper part of the body, especially face and neck region, and also a little bit of upper trunk, supraclavicular area, etc., over the shoulders, you can see there is actually fat over there. And in some cases, even that fat is accumulated, which can give these patients a little bit Cushingoid appearance. So that's why many of these patients with familial partial lipodystrophy, they are tested for Cushing disease at some point. So there is this diagnostic additional challenge in familial partial lipodystrophy as well. So that's the overall definition, and very rough and very summarized version of a classification.
Okay, and the second question is diagnostic of lipodystrophy easy?
Yeah, that's a great question. Unfortunately not. So I just brought this slide with me just to show you how long would this take to diagnose patients with lipodystrophy, even in an experienced center. So this is a study of it's a retrospective analysis of 230 patients from 3 different countries, United States, Turkey, and Brazil. So, and as you can see, there are quite good number of patients with both forms, generalized and partial lipodystrophy here. So the striking finding in this study, so there is a lot of additional findings in the study reported, but one striking finding is, so it takes quite a time for these patients to come to a physician with their symptoms. So if you look at generalized lipodystrophy, so it takes overall around 9 years for them to come a physician, and for partial lipodystrophy, it's more than that, 24 years. So most of the patients in this study, they had congenital generalized lipodystrophy in the generalized lipodystrophy population. And in this version, these people are born without fat. So typically, the disease can be actually recognized at birth, but still it takes time for them to come to a physician attention. But it doesn't stop there. Actually, it's not the end of the story. At some point, they come to a physician with the symptoms of lipodystrophy. They say something is wrong with my child or something is wrong with myself. but still it takes years for physicians to diagnose, recognize them. It is around 3 years for generalized and around 9 years for partial lipodystrophy. So this is due to several reasons. First of all, it's a rare disease. The awareness among the medical community is not great, and the disease itself is a complex disease. So it is really not very easy to diagnose them if you are seeing them for the first time in your life.
Okay, thank you. And what are the main complications associated with lipodystrophy?
Yeah, these patients come to our attention because of their phenotypic features, sometimes fat loss, and their muscular appearance, visible veins, etc. But also, there are complications and metabolic abnormalities in these patients, and these are very important for us to recognize because these patients, they usually develop insulin resistance quite early, and this insulin resistance becomes very significant during early years of life. And then at some point, it causes diabetes. And when it causes diabetes, it's usually very difficult to treat with standard medication. So if you have a patient with difficult to control diabetes, or if you have a patient who is developing insulin resistance quite early, but the person is skinny, not obese, right? So then you have to think about this disease, right? So because there is this disproportionate appearance of the patient and also metabolic abnormalities. There is this, disconnect there. So this should be something that is ringing the bell for you for the suspicion of lipodystrophy. So there are also lipid abnormalities. These patients, they usually have low HDL. This is one of the earliest symptoms. And they also develop high triglycerides. And this hypertriglyceridemia over time becomes really very significant and may cause pancreatitis. So they develop liver disease, steatotic liver disease quite early because they cannot store energy in the fat compartments, adipose compartments, and this energy has to be stored somewhere else. That's excess energy too. So, and liver is one of the organs to be affected by this ectopic deposition of energy here, fat. So, and this causes also liver problems. And the cirrhosis is not very rare in these patients. Even as young children, they can develop cirrhosis. So they also develop proteinuria renal disease. So in some patients, there is additional etiology like glomerulonephritis, but even significant insulin resistance itself may cause significant proteinuria in these patients. So they're at risk for heart disease because they have this atherogenic lipid profile, and sometimes molecular etiology also contributes. Some of them, they may suffer from very severe forms of arrhythmias. And also reproductive health is affected because they are insulin resistant, and they also lose a very important adipokine signal, which is leptin. So in the absence of leptin signal or impaired leptin signal, their reproductive health is also affected because leptin has multiple functions. And nowadays, we are also learning from our patients about their additional symptoms like chronic pain, fatigue, or, psycho-emotional problems.
Okay, and how can we diagnose lipodystrophy?
Yeah, diagnosis is a bit challenging, to be honest. As I said, this is a heterogeneous rare disease, so there are different forms, and sometimes these forms are not alike each other, so they can be quite different. It's a broad spectrum of clinical presentations, and we don't have a single test to diagnose lipodystrophy. And there are lipodystrophy-like phenotypes. They look like lipodystrophy, but they don't have the disease as a complete disease. So, and in young patients, sometimes they come to physicians, but their metabolic disease can be mild when they are younger, or fat loss may not be clear. And in males, muscularity could be treated as a normal thing because, the physician may just simply think, oh, this male with muscular appearance, that's kind of normal. But we have to always keep in mind why this muscular man is having these metabolic abnormalities, right? This is the question that we have to ask ourselves. So the first thing is we have to remind ourselves, subcutaneous fat loss, that's the most critical symptom. And also, as I said, we have to consider lipodystrophy. if there are metabolic syndrome, the symptoms, which are disproportionate to the body size. For example, diabetes with high insulin requirements, hypertriglyceridemia, liver disease, steatoid liver disease, or fertility problems. One thing that could help is looking at the photos from the patient through their lifetime, because you can document the progression of fat loss by looking at these pictures. And also, especially familial partial lipodystrophy subtype, most of these patients, they have autosomal dominant disease. That's why if you have other family members with the same phenotype, that can help you to diagnose them. So for acquired versions, autoimmunity could be something that can help. And you have to do metabolic testing, right? Just to see whether there are metabolic abnormalities in the context of what you're looking for. So skin fold thickness is something that you can do in the exam room. So, but one thing to keep in mind, these values, for example, anterior thigh skin fold values listed here, these are just some percentiles of normal. They are not diagnostic. They are just good for screening. This is just something that can help to, strengthen your suspicion about the disease. They are not going to make the diagnosis for you. So how can you then make the diagnosis? If this is a genetic form, nowadays we have genetic testings available. So you can simply diagnose your patient by a genetic test if you're lucky enough. Why I'm saying that? Because not all patients have genetic mutation, even though they have a genetic form of lipodystrophy. For congenital generalized lipodystrophy, almost 90% of them, they have one of the known genetic variants. So this will leave another 10% where you may not find anything. And for familial partial lipodystrophy, this is actually worse. Around 60% of them have genetic, diagnosis, and for the other 30–40%, you may still not find anything. So this could be because maybe the diseases are not fully discovered yet, although there is a significant improvement over the last decades, last 10 years, I would say. But still, there are additional genes to be discovered. And the other thing is, some variants of familial partial lipodystrophy, we believe they are polygenic, they are not monogenic. That's why it's not easy to, document the gene defect causing the disease. So nowadays, whole exome sequencing is becoming increasingly available. So this may also help for future. But just to keep in mind, if genetic testing gives you diagnosis, a typical variant, then you're good. But sometimes you may find something that may not explain the disease, or you may not find anything at all. So then you still have to do things to diagnose your patient. So everybody asks about leptin assay because these patients are leptin deficient, right? So if we measure leptin, can we diagnose them? That's partly helpful, but unfortunately, this is not diagnostic because leptin levels are, first of all, leptin tests are not standard, or different tests that people are using, they're not interchangeable. Somebody is using one ELISA, other lab is using another ELISA, and these values can be different. So for most populations, we don't know what is normal because leptin levels change over time by gender, by ethnicity, different things. So that's why if you have a low leptin, especially for generalized lipodystrophy, they usually have low leptin, very low. This is really helpful. This is really supportive. But if you have a normal leptin, this is not going to rule out your diagnosis. So in short, leptin levels are helpful, but they are not diagnostic. They cannot be the only test for you. So imaging is great. You can do DEXA or MRI to document fat distribution. So MRI can provide you additional details too. It's high resolution image compared to DEXA. But DEXA is easier. And then most centers, they can do DEXA, but especially whole body MRI is a bit difficult to run. It's also expensive. But imaging radiology is a very helpful way of documenting fat loss. So yeah, I mean, as you can see, unfortunately there is no single tool to diagnose them, but if you combine all of these things that I was just explaining, so I think the diagnosis can be still made.
Thank you. And were there any helpful tools that can help us in the diagnosis of lipodystrophy?
Yeah, so let's start with this one then. So I think in Europe, we have additional tools, but before that, I have to just show the guideline on lipodystrophy. That is a bit old, unfortunately, from 2016, but still this guideline can serve as an important tool to understand the disease, different types, and diagnostic, approach. Still very valid. But in Europe, you have this great option. That's the European Lipodystrophy Consortium. So, and European Lipodystrophy Consortium has this Ask the ECLip expert option. So this is a group of experts from multiple countries, a little bit actually expanding beyond Europe. So, and then, so these people are likely seeing more patients than yourself in their routine life, and they also have their years of experience, clinical experience in diagnosing these patients. So, and then ECLip is now offering this. So if you have something to discuss with an expert in your region, in your area, so you can use this tool. So you can just go to the ECLip website, and then you can just request this help from one of the ECLip members, and then they will contact you, and they will, just try to understand how they could help you with your problematic case. That's very helpful too. So there are also additional papers, and one example is this rapid action plan that we wrote, I believe, now more than a year ago. So it's not a guideline, but this is specifically designed for younger physicians, less experienced physicians. This is not for experts. This is just for, general audience, I would say, because in this paper, we try to simplify things for trainees too. So there are diagnostic checklists like this. So you can find stepwise approach to diagnose and also understand the disease state. So I think that's a very helpful resource as well. And there are additional things. There are several groups in different parts of the world trying to improve the diagnosis of lipodystrophy. One tool is a mobile application from Spain. Dr. Araujo developed. It's a very helpful. It's free. You can just download it. So it will help you to distinguish between different lipodystrophy subtypes. The Brazilian work in the middle is like very innovative, but still not available. But just to let you know that people are trying these things as well. And also there is another thing called lipodystrophy severity score that we developed more than a year ago. This is actually a tool that can, assess the disease burden, but it also can serve as a diagnostic checklist because the lipodystrophy severity score has all the right questions to ask. So you can use this tool, and it is also available online to see what questions you need to ask your patient or what, metabolic disease, parameters needs to be checked, things like that. So this could also be one of things that can help you with your daily routine practice for lipodystrophy.
Great. And the last question, what are the treatment options?
Yes, so that's a very good question, and I will answer this very shortly, but I think it requires another hour for us to discuss. So if you look at the treatment options, I think there are two things. First, standard treatments, and the second part is lipodystrophy-specific treatments. For standard treatments, these are very similar to what you do in your clinical practice for patients like type 2 diabetes or lipid abnormalities. So you technically use standard treatment modalities to improve the metabolic health of your patient. So this could be anything. So, and based on your patient's needs, you can, use combinations. You can use insulin to treat diabetes. GLP-1 analogs can help. SGLT2 inhibitors, metformin, and for lipids, statins or fibrates. So you can try different standard approaches to treat your patient. But in most patients, especially in generalized lipodystrophy, almost in all patients, I would say, unfortunately, these standard treatment approaches fail. So, and then in that sense, there is this lipodystrophy specific treatment pathway. For that, as of today, the only approved treatment is leptin replacement, because patients with lipodystrophy, they are leptin deficient. And if you replace this critical hormone, you can improve metabolic health. That's the idea over here. And there are also additional investigational agents which are being tried for lipodystrophy. That's also good news that the field is making progress on that. For generalized lipodystrophy, leptin-based treatments are first-line treatments. So if you treat these patients early with leptin replacement, you usually end up with better outcomes. There are very nice studies from NIH showing this. For partial lipodystrophy, the situation is a bit different, though. In partial lipodystrophy, leptin replacement is usually second line, which means first you have to try standard treatments, and if they fail, then there is leptin treatment over here, and then you can combine these treatments too. That's also possible. So, but this is second line. For generalized lipodystrophy, first line. So, and after saying this, I think I can conclude my presentation. First, I have to, again, acknowledge that this is a difficult disease state, and it is a real diagnostic challenge. So, especially if you're seeing your very first patients, that could be really difficult. But as I said, there are, resources. There are people that can help you. So, you have to combine different, diagnostic modalities, and then physical examination. That's always the most important thing. You have to do a full physical examination. You have to undress your patient. If you don't look, you don't see. Okay. So because unfortunately nowadays everything is digitalized. So, and we are sometimes forgetting the importance of physical examination. This will remind you this again. So full physical examination is the most important thing for lipodystrophy diagnosis. And then you have to combine it with metabolic testing, imaging, genetic testing, etc. So you have to remember these patients, they have a serious disease, and they are at serious risk of morbidity and mortality. If not well treated, if not recognized, unfortunately, especially patients with generalized lipodystrophy, they may die as young adults, even as children. So that's so serious. So it requires a multidisciplinary approach, because as you can see, there are different organ complications, there are different symptoms. So you may need to, collaborate with your colleagues. So this is a difficult disease state. So, and there is no cure for lipodystrophy. We don't have any treatment yet to bring fat tissue back. However, we can still treat, especially metabolic disease in these patients effectively if we follow a right multidisciplinary approach for these patients.
Thank you. Those are all our questions. Thank you, Professor, for this great lecture.
Thank you again for your invitation, and I wish you best success for the future videos. Thank you.
Thank you.
Thank you. Bye.